Okay, so I will talk about the state of Ibogaine in Brazil. Again, I thank for the opportunity to be here. I thank you, especially Peterson and Gaetano, a friend of some time. And that is that I'm a physician. I work with Ibogaine for 30 years. I'm involved in Ibogaine scene for a long time. 30 years ago, when I started to work with Ibogaine, it was because of needs. It wasn't so well known, and I'm very happy to see and to hear about a lot of things about Ibogaine nowadays. But in the past, nobody was talking about Ibogaine, so it's great to see it. But it emerged here in Brazil as a necessity because, as I said, we have a big problem with crack cocaine. It's really complicated. You see, we have this, what we call the cracolands. So, see, in Portuguese, it's Cracolândia. So it's this scene. It repeats in every major city in Brazil, a place where a lot of people, sometimes thousands of people are using crack cocaine in open skies. Only São Paulo city has 43 cracolands, so it's very complicated, and it's not a matter of policy. It's more like a public health problem. So we need something to help with this, and Ibogaine is perfect to help with this. So in 2015, the São Paulo State Council on Drugs Policy tried to regulate Ibogaine because, as I said, Ibogaine is not scheduled here. It wasn't even regulated. So this first initiative was to a beginning of a regulation here, and the State Council decided that it would be mandatory for Ibogaine treatments to be done in a hospital, to be done with proper medical assistance, psychological assistance, nurses, and all the equipment, trying to avoid complications, and it's working. We've been able to do treatments with no complications. In Brazil, it's possible for you to import Ibogaine, but it's a little bureaucratic because you must import it in the name of the patient and dose by dose. So if a patient decides to do Ibogaine now, we must fill a lot of papers to import it. And if another patient decides to do Ibogaine in a few hours, we will need to open a new process to import again because it must be separated. We cannot import 10 doses at a time or 20 doses at a time. We must import dose by dose, so it makes things complicated and expensive. But it's the way we can work nowadays, so that's what we're doing. Ibogaine that we use here is from Voacanga africana. It's HCl ibogaine from Voacanga. This eases a little the importation because there are not the Nagoya Protocol to complicate even more the process. And this is a timeline of Ibogaine in Brazil. So in 1994, we did the first clinical treatments. In 2013, we reached 1,000 patients treated. In 2014, we published the first paper here in Brazil, treating drug dependence with the aid of Ibogaine. It was a retrospective and quantitative study. And it's interesting to see that almost right after this publication, the Drug Policy Council in the state of São Paulo started the regulation. After that, Anvisa included Ibogaine in the pharmacopoeia. Is the first country in the world that has Ibogaine included in the pharmacopoeia. This is an important step because the pharmacopoeia, as you may know, is like the list of the substances that are that the government think that can be medically useful. So it's the opposite of the Schedule 1, which states that Schedule 1 has no medical value. The pharmacopoeia means that it has some medical value that need be studied, that need be researched, but it's a door that is that opened it. In 2017, we published the second paper about Ibogaine, the same team. It was a qualitative study. that showed how the patients change after Ibogaine, and another study, a phenomenological analysis of the experience. And after that, we reached the 2000 milestone of patients' treatment. In 2020, we started to prepare the protocol for the research. What we want to do is to register Ibogaine in Anvisa. Anvisa is our FDA. We want to register it. If we register it, it will be officially totally regulated in Brazil. We won't need to import it dose by dose. It will drop the price. It will ease the process. And to register it, Anvisa is totally open to help, to accept the registration. Anvisa asked for a phase 2/3 research, IRCT research. And after registering, we will be able to provide Ibogaine in the public health system, and insurance will have to pay for Ibogaine treatment. So this is our goal. This is what we are aiming for. We want to have Ibogaine here totally regulated, to expand access. Our goal is to expand access, and we decided to expand access following the rules of Anvisa. So we are in a work with Anvisa to reach this. We submitted this research to Anvisa, but we didn't start the research yet. We plan to start the research the next year, but we are going. This is the work, the first paper that we published here in Brazil. And this was important because of the conclusions. It's a retrospective study. We understand it's not a RCT, so it has not the same value of a RCT, but it's important because of the conclusions. The conclusion of this work is that Ibogaine treatment, when conducted in a hospital under continuous medical supervision, using good quality, high purity Ibogaine, appropriate dosing, integrated psychological support, is effective and safe. Nobody died. Nobody had any kind of complications. Everything was fine. And 72% of the patients, and this study included alcohol, cocaine and crack cocaine and heroin patients, the mean was 72% of the patients were fine during all the time they were followed. So it's a big difference from the traditional treatment. So this is the importance of this study, showing that Ibogaine works and Ibogaine is safe since done in the proper way. So this is the Brazilian model for regulated Ibogaine: hospital-based, medical supervision, good quality medicine, proper monitoring, proper dosing, psychological integration, and this is most important, regulatory clarity. It's super important for the patients to feel that they are doing something that is regulated. They are not doing something underground. And for the team, the doctors, the nurses, the psychologists, it's important to feel that they are doing something that is legal. They are not doing something underground, because when you do a treatment, an Ibogaine treatment, it's you are under a pressure, and if you have, besides this pressure, because you are worried with the patient, you are willing that the patient goes well, but if besides this pressure there's another pressure that you are doing something wrong, that's something illegal, it's too much complicated. So it's important that for the team, the people that will be working with Ibogaine feel that they are in a regulated situation. They feel they are safe too. Not only the patient must be safe, but the team, the therapeutic team, must feel safe. In Brazil, we have what we call the SUS. The SUS is the Unified Health System, or the Universal Health System. It's a system that is paid from the taxes that people pay, and everybody has the right to access. We have the private medical care, but we have the public medical care, which is the SUS. So anyone that needs can go to a hospital or to a public medical office and be treated from anything. Even if you are a tourist, you have a problem in Brazil. If you are an American tourist, you break your leg in the street, you'll be driven by an ambulance to the hospital and will be treated for free, even if you need a surgery. This SUS works perfectly with complicated problems, complicated disease. For simple problems, it doesn't work well. It takes a long time for you to get a consultation. If you need any procedures, it will take a long time. But if it's an urgent matter, if it's a really serious problem, you'll be treated very quickly. You'll be under surgery very quickly. Even if you need expensive procedures like a heart transplant. Here in Brazil, if you need a heart transplant, you do it for free. You won't need to pay anything. The problem would be finding a compatible donor, but not the procedure itself. So it's a thing that we Brazilians are proud of. And our dream is that we could integrate Ibogaine in the system. So we think that registering Ibogaine in Anvisa, getting the recognition of Anvisa that Ibogaine is a real medicine and it really works, we think that in the future, Anvisa would allow the Ministry of Health to provide Ibogaine treatments in an organized way. But we think that the first step would be doing this research that I mentioned and approving it in Anvisa to import it not as an exception, not as an exceptional rule, but as a normal rule. So this is our team dream, to integrate Ibogaine and after that other psychedelic therapies in this way, in the SUS, in the way that the public mental health policy works. So that's what we are trying to do. It's not so simple. By the opposite, it's very complicated. There are people that don't like Ibogaine, you know. There are people that simply don't understand Ibogaine. And there is this, sometimes people really think, as we were talking before, people think that Ibogaine is super dangerous and we don't need to even touch it. No, Ibogaine done the proper way, it's safe, it's effective, and it's a thing that we must invest on. Because I always say this, if we were proposing something to treat like flu, I would understand. We have a lot of medicines to treat flu, so it's okay. But we don't have medicines to treat the kind of mental health problems that Ibogaine treats. So it's important to pay attention on this. Ibogaine teaches us that healing can be biological, existential, and what is our mission, and when I say our, I mean everybody here, is to turn this potential into policy and that vision into action. So that's why I'm so happy with what is happening in the United States, because it will work as a mirror for other countries to follow the same path. And we are, everybody, we are here because of this guy and because of his wife. This is Howard Lotsof, his wife Norma Lotsof. They were the discoverers of the anti-addiction properties of Ibogaine. We must thank them. We must thank the other people too, like Dana Bill, the activist, and Bob Cisco, friends of them. So these guys were the first people that understood Ibogaine, that understood that it would be useful, and started this path that nowadays all of us are going through. So thank you for these guys, for their work. And thank you, the audience, and thank you for the invitation, for being here. Thank you very much.
Thank you very, very much, Bruno. You know, you said it was the paradigm for Brazil's Ibogaine program. I really think, did you notice when he was going down the list of all the studies and all the roadmaps, it was Rasmussen, 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 Rasmussen. I think it's just the Bruno roadmap.
Yes, but Bruno is my name. Rasmussen is my surname, but I'm. It doesn't matter the name. I think that what matters is finding people to work towards the total legalization of Ibogaine. This is what imports, what means, what's important. So it's that.
Beautifully, beautifully said. All right. Well, again, thank you very much, Bruno. With that, we will turn the time over to Dr. Maurice Hinson. He's going to be speaking about many of the same considerations, what that looks like in the US model. Dr. Hinson.
All right, good. So once again, my name is Dr. Maurice Hinson. I'm a general internist by training. And so I'm challenged today to speak about the clinical perspectives of implementing Ibogaine in a US clinical model. But I just want to first thank Catano and Peterson for the invitation. All right, and hopefully you get something from it. Okay, great. Okay, so my discussion is really from the perspective of being a completely Western trained physician. All right. I went to Hopkins for undergrad, got my bachelor's in neuroscience, then Drexel right here in Philly, born and raised. All right. Then I went on to New York. That's right. But I'm not an Eagles fan. I'm a Cowboys fan. So let's not get confused. Oh, is the talk over now? Talk over? All right. It's fine. I set myself up, right? That's right. So, but then I went on to New York and did my training in internal medicine at Cornell. And so I've had the honor and privilege of being trained at some of, our most prestigious institutions. And while I fully embrace Western medicine and its advancements and technologies, especially as AI is getting more and more introduced, I am much more a naturopath in spirit and in practice. And I'm of the belief that the real power of AI is not in artificial intelligence, but rather ancestral intelligence. All right. Because what I've noticed throughout my education and my training, that there is nothing that man can create that comes even remotely close to the power of God. And if you don't believe in God, thank you. And if you don't believe in God, then surely you believe in nature, because that's all around us. All right. And I think that the solution to many of our most challenging health-related issues will be found in nature. And we see that with mental health. All right. Here I'm discussing the treatment conundrum. All right. And I break it down into two parts, structural and perceptual. You won't see this in any textbook. This is more Hinson Medical Theory 101. All right. But basically, if you consider the mind like a computer, which that analogy was given several times earlier, you have the hardware, the computer, the keyboard, the mouse, and then you have the software, the coding, the language behind the operating system. Well, the mind is very similar. All right. We have structural parts, genes, proteins, metabolites, brainwave activity, neurons. Okay. This is the structural component of the brain and mind. Whereas the perceptual part is in our associations, perceptions, our beliefs, the awareness, consciousness. These are things that we can't necessarily quantify, or at least not easily. And our pharmacologic therapies and transcranial magnetic stimulation and electroconvulsive therapy, these address the structural components of what I'm discussing. Whereas therapy like cognitive behavioral therapy, dialectic therapy, hypnosis, this addresses the perceptual. Now, rarely do either of these impact the other, all right? In fact, I've spoken to a number of psychotherapists who've said it takes 15 to 20 years of therapy to do what Ibogaine can do in one dose, all right? And so this is what Ibogaine represents for us. It's for the first time, we have one unique compound that's able to not only impact us on a structural level, but also on a perceptual level. And so what I want to do is discuss how we build this into an American medical framework, all right? And I'm going to start with this spiritual significance, because that's where it starts, okay? That's the greatest deficit that we have as a society, and so we have to bring this back into the main fold, okay? Talk about the legal and regulatory implications, all right? What can I do? What am I allowed to do? What am I prohibited from? What are the gray areas that might get me into trouble? What are the gray areas that I might be able to exploit, right? The scientific framework, and lastly, the practical considerations. So first and foremost, we are spiritual beings, all right? We're spiritual beings in a physical vessel having a divine human experience. We are not physical beings with a spirit. It's a distinction that must be made because it's setting the tone for what we should be prioritizing, okay? The problem is spirituality is absent aside from religion, and even in religion, you can question it, but spirituality is absent from most of our societal institutions, all right? And so as such, man's greatest deficit, our greatest disease is of the spirit. And one of the biggest and most profound elements about relearning our spiritual self is learning that all is one. Everything is interconnected, all right? Mind, body, spirit, the interconnectedness we share with each other, with our earth, with the universe, okay? All is one, all right? And that we sort of have to get away from this idea of two sides to every coin, all right? Things aren't dual in nature. There are no opposites. Everything exists on a spectrum, okay? Dark is not the opposite of light. Darkness is just the absence of light. There's a spectrum, okay? That spectrum can also be applied to what we consider as our drug therapies, right? The biggest issue right now with Ibogaine is that it's considered too cardiotoxic, right? It's poison, it's toxic. But on the other hand, you've just learned about people, providers and patients who find it completely transformative. So how can one thing be both? How can one thing be both a poison and a medicine? Snake venom, most people would say is a poison, right? Snake bites you, you might lose a limb, might go into anaphylactic shock, you might die. But if you take that same venom and dilute it, that snake venom is now able to fight cancer. It's a blood thinner. It's a blood pressure medicine, right? That spectrum is the concentration. Water, no one would consider water to be a poison, but you could drink too much water. In fact, I took care of a woman in the ICU who drank so much water that she died. She depleted her electrolytes and she died, all right? So there's a spectrum, and that spectrum also exists when it comes to Ibogaine, all right? The one biggest thing that differentiates whether Ibogaine acts as a medicine versus a poison is in preparation. And you heard this theme several times throughout this morning, especially from Dr. Bruno, who actually assisted me in putting this presentation together. Preparation. The more we prepare, the greater the therapeutic benefit. The less we prepare, the more we get into trouble. So first, the legal preparation. It has to be rescheduled. And this is where I differ in opinion with psychedelics, or at least Ibogaine, and cannabis. I think cannabis should be completely descheduled, all right? I think it has a far less risk profile than any psychotropic, but Ibogaine, used in the wrong hands, will destroy this whole movement. And so I think it should be regulated in a medical setting, all right? So Schedule 3. This allows for regulated medicinal use, human clinical trials, will allow then the FDA to take a look at it and say, hey, let's approve this thing, and will influence our insurance companies to cover it for reimbursement. Now, this is critical to allow for equitable access, all right? Right now, only those who can afford it are able to gain the benefit from it, and that's deplorable, okay? And lastly, it should be a state-regulated, like Department of Health process. Now, when I took my Hippocratic Oath, we said, first, do no harm. So I understand looking at Ibogaine in terms of its adverse effects. We should do that. We should determine the risks before the benefits, all right? So let's talk about it. Let's understand Ibogaine briefly, all right? This onset of action has got a long duration of action, and actually its metabolite has an even longer half-life, okay? So we have to be careful when administering. We can't take a dose and then just go out an hour or two later, all right? There's a long duration of action. We heard several talks about its mechanism of action, and this is just a few, okay? We're learning more and more about its mechanisms. We also are learning how it's metabolized, okay? It's metabolized by the liver, cytochrome 2D6, all right? It targets the HERG potassium ion receptors, and that's what leads to its cardiotoxicity and its prolonged QT, which then can develop into a lethal cardiac arrhythmia called torsades de pointes, okay? And I just want to highlight several areas, right? It's where it impacts serotonin reuptake, the metabolizer, and its prolonged QT. Because when we discuss how to mitigate its risks, we should look at those specifically, okay? So we should avoid concurrent use of SSRIs and SNRIs, all right? Medications that are metabolized by cytochrome 2D6, any agent that prolongs QT, and there are many of them you'll see shortly. And some of our absolute contraindications are patients with a prior history of schizophrenia, psychosis, ventricular arrhythmias, and those with liver failure. And by liver failure, I mean reduced synthetic function. Okay, so reduced protein, elevated coagulation factors, okay? These are critical things to assess and rule out before administering the dose. And this is a list of commonly prescribed medications that are metabolized by cytochrome 2D6, all right? We see everything from the SSRIs, SNRIs, metoprolol, carvedilol. These are commonly prescribed blood pressure medications and heart failure medications. Zofran, the antiemetic, Robitussin, okay? Tamoxifen, which is for breast cancer, all right? So we cannot have concurrent use of these medications. And here's a list of QT prolonging agents. This we should also not include during the time that we're dosing Ibogaine, all right? And we see levofloxacin, Levaquin, a commonly prescribed antibiotic. Furosemide, Lasix is a diuretic. We often give these to heart failure patients. But I want to highlight these last two, buprenorphine and methadone. Because right now, these are the standard of care for medication-assisted therapy, all right, for people who are suffering from opiate use disorder. Now, what's interesting, as I mentioned, is these also prolong your QT, but this is the standard of care. And so for people who oppose Ibogaine because it prolongs QT and increases risk for cardiac arrhythmias, then why are we okay with methadone and buprenorphine? Methadone and buprenorphine, well, let's start with methadone. Methadone has been found to result in the death of at least 3,000 patients annually, all right? Suboxone, a little less, several hundred annually. But from what I can find, and this is over 35 years of documentation, I've only seen about 120 documented deaths from Ibogaine, all right? So they carry supposedly the same cardiac risks, but methadone and buprenorphine are far more lethal, okay? So this to me is not only ironic, but it's hypocritical, right? So we should not be banning Ibogaine because of its cardiotoxicity, okay? First, from a clinical perspective, scientific framework is gathering patient information. This is critical. Now, in my practice, I have an integrative practice in Brooklyn, New York, and every patient undergoes a biopsychosocial assessment. We're not just concerned about your medical history. I want to know your psychological history. I want to know where you live. I want to know what's going on with the family. I want to know your stress level. All of these things are important factors when determining who's eligible for this particular treatment. So again, reason for seeking therapy, history, especially cardiac history, past psychiatric history, current medications and herbal therapies. I'm seeing a wave, especially where I'm at in Brooklyn. It's in Flatbush. It's a huge African and Caribbean population. And so everybody wants that bush medicine. Everybody's on a herb, okay? So understanding what herbal therapies are is critically important. If they're on any current illicit substance. And again, their housing status. You don't want to give someone an Ibogaine dose and then they go back to a shelter. Or they go right back to that same abusive home, which is why they're there to see you in the first place. All right, so we have to be cognizant of these issues. And then social support, also critically important, because after the dose, I don't want to discharge them from the facility by themselves. All right, I want them to be around someone just in case, the Ibogaine is acting longer than we expect, just to have that emotional support around them. All right, so social support is critically important as well. Any patient should have a basic screening, okay? A complete metabolic panel where we're looking at electrolytes, especially magnesium, okay? So what we find is that people with magnesium deficiency are at increased risk for developing torsade de pointes. In fact, that is the solution, that is the treatment for this cardiac arrhythmia, all right? The problem is serum magnesium is a poor indicator of intracellular magnesium. And so what I suggest is that we start looking at RBC magnesium. This is a true measurement of intracellular magnesium, okay? And then you treat accordingly. We need to look at liver function again because Ibogaine is metabolized by the liver. Coagulation factors, EKG, echo, we wanna look at the structure of the heart. And a diagnostic psychiatric evaluation, okay? We want a baseline screening assessment, PHQ-9, GAD-7, CAPS-5. So somewhere that we can see where we start and then the effect of the medicine. Okay. Just to discuss patient preparation. So after we identify an eligible patient, then it's time for the pre-administration medical and psychiatric optimization. And this happens in several steps. If we identify any issues in the screening, like electrolyte deficiency, obviously we want to replete that. Medication washout period. Now, this is critically important because most of the patients that you see have some sort of issue and are likely on one of these medications that I said don't use concurrently. Well, we need a washout period, but how do you do that safely, right? Someone who's on an SSRI, SNRI for over a year, you can't just take them off and say, okay, we'll do Ibogaine tomorrow. There requires a washout period. So patients may be inclined to say, well, this is the only way that I feel okay getting up and going to work or going to school or interacting with my family. I can't just stop. Well, this is where we have to get a little creative about alternatives, all right? And during some protocols, they use like ketamine, which is a shorter acting sub-anesthetic that actually helps to bridge patients from their SSRI to Ibogaine therapy. Or for those who are on methadone, for example, using morphine, all right? We just discussed the benefit of long-acting morphine in these patients. That's probably most ideal, but we have to get over, insurance barriers and things of that nature, okay? And then the preparatory psychotherapy. So this is having sessions, therapeutic sessions, psychotherapy sessions before the dose to prepare them. Expectations, exploring the diagnosis, setting intentions, because it's all about intentions, okay? And so at minimum, if you had the perfect patient that wasn't on medication, which is highly unlikely, it would still require a minimum of 2-3 weeks just to get them prepared through the psychotherapeutic sessions. But could be as long as a month, maybe 6 weeks if they have to be weaned off one of these medications, okay? On a day of dosing, what I'm suggesting is that this be done in a hospital-like setting, all right, that has all of the cardiac resuscitation equipment necessary, transvenous pacemakers in case a cardiac arrhythmia occurs, intubation and ventilation equipment, that you have professional staff that's trained in resuscitation, licensed facilitator, psychedelic therapist, someone who sort of expects or who knows what to expect, and having guides. And I'm a big believer in having both a male and female guide just to have that balance of masculine and feminine energy, Now we're talking about having to pay more and more people, but I do think that's critical in this part of the journey. And then dosing. Dr. Bruno discussed dosing. I gave the average that they use, but it really depends on the person, how sensitive they are to it, what you're doing it for, how severe the condition. But this is somewhat an average, 15, 20 milligrams for men and 12 to 16 for women, all right? And then post-treatment monitoring, okay? Continuous tele, all right? Identifying if a cardiac arrhythmia is beginning and then intervening before it gets too bad, too worrisome. Doing Q1 hour, so every hour vitals, just to make sure that they're hemodynamically stable. And then having a 24 to 48 hour stay, okay? You can't just take the dose and then discharge home. And then the follow-up. So the integration sessions are just as critical as the pre-screenings, all right? How do we take that experience and build it into something that's now positive, right? So discussing the details of the experience, identifying and unpacking these negative associations, and then introducing positive coping strategies. Again, we just heard how the psychedelics, especially Ibogaine, help to reopen this critical window where the brain is now far more impressionable than it is typically. So now we can introduce healthier coping mechanisms. And then journaling. I'm a big fan of journaling, and this is just, chronicling daily. Because when I haven't done Ibogaine, but I have done ayahuasca, I've done shrooms, I've done San Pedro, but what I noticed is that I didn't receive that blessing that day, all right? It happened over time. And so as I was documenting, I saw how things changed over time, all right? And I think it's critical to journal and document that experience and see how you progress. And I'm coming towards the end. So the practical considerations, how do we make this a viable and sustainable model, all right? Because yes, this is the right thing to do, but it also has to be financially viable, okay? Again, first, it has to be rescheduled, all right, to class 3. Research. Gaetano loves to say, what is it? In God we trust, all others bring data, all right? So we need the research, okay? We need FDA approval so that we can then manufacture Ibogaine in the US. Let's reduce the costs, all right? Operate as state-regulated treatment centers and reimburse, here's what the big kicker is, reimburse under observation status, okay? For those who don't understand, so we have inpatient admission, we have outpatient stays, all right? Observation stays, rather. Observation stays are significantly less costly to insurance companies, all right? But they have an expiration of 48 hours, which is perfect for administering Ibogaine, okay? So with these stays, you have hospital-level monitoring, trained staff, and again, it's far less costly to insurances, and they'll be more inclined to reimburse for it, okay? This I don't have to really go through. Tons of people are impacted by opiate use disorder, depression, PTSD. I'm only listing these 3 just for the sake of space and time, but I feel like Ibogaine will have a far larger reach once we fully understand how powerful it is. So everything from dementia, everything to neuromuscular disorders, spinal injuries, okay? We're just scratching the surface of how powerful Ibogaine is, okay? And the economic impact. So opiate use disorder, depression, PTSD have direct costs of $107, $134, and $76 billion respectively. All right, that's direct costs. But when you factor in everything else, work loss, premature death, hospitalizations, it's in the trillions of dollars. And so the economic impact is unbelievable. And it's return on investment. So if you consider that the average opiate use disorder patient costs $163,000 annually, that saves the system $2.1 million, okay? All right. And so the return on investment is obvious. And just to bring everything together, so I started off talking about the importance of spirituality. And I do feel we need to lead with that. Let that be the guide to our moral compass, because it is our moral obligation to bring forth safe and effective therapies. We can no longer remain complicit and continue to allow the exploitation of suffering for financial gain. And understand that there are ways to do good and make money. You know, these two things do not have to be mutually exclusive. And when we prepare the right way, Ibogaine will be the perfect example of how we can explore that opportunity. All right. So with that, I thank you. I do want to give a special thanks to Dr. Bruno, who you just saw, because he, he sat with me several times to walk through what he does in practice. Obviously, I'm not administering Ibogaine in the U.S., so a lot of this is based off what he's done, over 2,500 treatments, 0 deaths. So we just have to figure out how to put it within the U.S. clinical model, right? Thank you.
Wow. Again, absolutely phenomenal. I think just beautiful perspective about how we so often miss the amazing for the good. We can be so hypocritical sometimes, and there's so much opportunity for, as Dr. Hinson said, for us to do good and save money or make money.